Sir, to please come and chair the session. Now I would like to request Dr. Kashif Malik, who is Professor of Gastroenterology and Head of Gastroenterology and Hepatology Department, Federal Postgraduate Medical Institute, Sheikh Zayed Hospital, Lahore. Dr. Kashif Malik, please come on the stage and co-chair. I am pleased to introduce General Tasawwur Hussain, who is second co-chair of this session. General Tasawwur Hussain is a professor of medicine, currently working as Professor of Medicine, Foundation University Medical College, Islamabad. Professor Tasawwur, please come on the stage. So, first lecture of this session will be delivered by Dr. Bilal Hamid, who is Associate Clinical Chief and Program Director for Transplant Fellows at University of California. He will highlight the aspects of non-alcoholic steatohepatitis, diagnosis and management. Dr. Bilal Hamid.
Assalamu alaikum everyone. Thank you to the esteemed panel for inviting me. Topic today, I'm going to talk about non-alcoholic steatohepatitis. And the theme is that it is a global problem. Yesterday we heard about hepatitis C as a global problem, but this is becoming the next. And hopefully this can keep our transplant hepatologists in practice for a long period of time. First of all, we have to understand the subtypes of non-alcoholic fatty liver disease. So we think about non-alcoholic fatty liver disease as two groups. One is patients who have just steatosis. And initially the thought that if you just had steatosis, these patients will not progress. However, there is new data coming up that if you develop more metabolic syndrome, the risk of progression is there. But the group of patients we are more worried about are the group which has steatohepatitis, which is defined by inflammation and ballooning. And this is the group of patients who are at risk of fibrosis. In our non-alcohol NASH CRN, which is the network by NIH, our pathologists came up with the criteria and we used that called NAS score, which is the activity score. And this is used for research, but we also use in a lot of clinical trials for this. And that does have ballooning, steatosis, and inflammation. And what we are trying to figure it out, that we think that rather than fat, the ballooning and fibrosis are the two most important things, which is in NASH. And identifying those patients who have inflammation and fibrosis is the most important to think about the liver-related mortality in these patients. So NASH is a progressive disease, fatty liver disease. So if you look at all the patients coming in, about 25% of patients from NAFL will progress or will have NASH. And out of those patients, 20% patients will have risk of developing cirrhosis. And these are the patients who have developed cirrhosis are at risk of developing portal hypertension, liver failure, and HCC. Also, NASH is becoming increasing as an indicator for liver transplantation. This is a little bit older data, but this graph is key. And the estimate in the next 20 years, it will is already overtaking hepatitis C, but it will take all the causes of liver disease. And therefore, identifying those patients who are at risk of progression is very, very important. They're estimated to about 25 million people in the US with NASH, and there are more than 20 clinical trials going on with this disease. So when I'm going to talk about some of the therapeutic, we won't going to have time to talk about all the new things, but this is very interesting and exciting field right now. So if you look at the prevalence, the general prevalence and what are the high-risk groups. So if you take all comers in the Western world, general population, the estimate prevalence is about 30%, and the NASH is only 2 to 5%. But if you look at the patients with type 2 diabetes, that number increased significantly. Up to 2/3 of the patients with diabetes in the Western world has evidence of fatty liver disease. And 50% of those patients will have NASH. And also obesity is a risk factor and up to 60% of patients with obesity have evidence of fatty liver, and 35% of these patients will have NASH. So also this is not unique to Western world. There's a lot of data from Asia coming up. This is an interesting study which shows that in India, the prevalence is more than 30%. And it's more about the urban versus the rural issue, and it's more seen in the urban. If you take Singapore, Japan, and China, so this is not, it's a global phenomena that we are seeing. And there are a lot of different factors that are involved in why patients in Asia is more, and therefore the lean NASH, the terminology with patients with a normal BMI is coming up. So if you look at the future, the diabetes, which is a huge problem in our part, the estimates are really concerning. In 2030, in India alone, the increase of 150%, and I would say that Pakistan will kind of mirror that. And you know, it's one of the very interesting stuff that one of the Indian team looked at this BMI. So this is on the left side, it's an Indian endocrinologist, and the right is a French physician. They have exactly the same BMI, but if you look at the body fat, the Indian has significantly high, and where you store the fat is a very, very important thing. There are new ways, actually, there are companies coming up that can define whether you have visceral fat or where the fat is distribution. So location of the fat is very important. So we are seeing more and more, even in America, I see a lot of Indian and Pakistani with fatty liver disease. So when you look at the disease progression, right, as we talked about, 2/3 of the patient will just have steatosis, up to 25 to 30%. But what about the progression? What about the fibrosis? So there are certain studies that done in that whether the change in fibrosis, and up to 18 to 22% can have regression of fibrosis. Majority will remain stable, but there will be a group of patients who will have progression. So identifying patients that who are at risk of NASH and fibrosis becomes important. So these are the clinical predictors of NASH, that which are the patients who have more risk of NASH. So this is not a complete list, but advanced age is a big, the greater the duration of disease, the more risk you're having NASH. What we're finding out that postmenopausal, so it's a very accelerated disease in women after menopause, and there's a lot of hormonal changes. One of my colleagues at UCSF is studying about this phenomena. In America, at least, we see that there is increased prevalence